Dr. Gakombe, I would really want to welcome you to this interview. And please tell us a bit about yourself. Maybe not too far, but just what you are doing at Metropolitan.
Thank you for having me. My name is Kanyenje K. I'm a medical doctor by training. I subsequently studied management because I found that running hospitals took more than a medical degree. And my current job is founder, CEO of Metropolitan Hospital, where we are seated. I wear several other hats. I run an IT company that focuses on healthcare IT, again born out of a need to computerize operations. And I'm the current chairman of the Kenya Healthcare Federation, which I was also involved in founding. Yes.
Okay, now I think Metropolitan is a big name, is a big brand, but let's just go back 26 years ago, starting off. What was the concept? Why did you take the plunge? And how tough was it starting?
First, the concept was very simple. We had a middle class which could not access quality healthcare. They could afford healthcare, but the existing private hospitals were beyond most of them. So our intention was to take care of this middle class, to provide them with quality, cost-effective healthcare. And we therefore chose a location where the middle class lives. Buruburu then was the largest single estate in the city of Nairobi, and we are just at the back of Buruburu estate. So that basically was the concept. And the founders were mainly doctors, and the motivation was because public hospitals were overcrowded. They're still overcrowded, but it was a lot worse then. Drugs were not available. It was basically a very difficult time when Kenya was going through structural adjustment programs. So we are trying to plug in the gap between the congested public sector, the expensive private sector. That's a space we chose to sit in, and that's a space we still occupy. As to how difficult it was to start, it was an interesting journey because first, a lot of people have trouble with youth. I try not to. So we were not considered to be old enough to qualify to start and manage a hospital. So that was one of the hurdles. Too young. You know, the Capital Markets Authority dismissed us. Most banks dismissed us. So to solve that problem, we recruited older doctors to join our board. Our current chairman was, we got him because of his passion for healthcare, and more importantly, because he was a more experienced healthcare professional, so, and older than us, so he could, occupy that seat and help us bridge that gap. The next gap was money. Interest rates then were in the 30% range. So clearly borrowing from a bank was not easy because of the cost of money. And secondly, banks were not lending to healthcare. They considered as a socio enterprises, so they were not very keen to lend to the health sector. And private investors were also few. So we solved that by selling shares to the public. We actually wrote a prospectus and walked door to door, relatives, friends, family. Many of the investors were from the healthcare profession because that's where many of the founders were from. So we got the money. The biggest investor was not a Kenyan. It was a British gentleman who underwrote the share issue. I was his investment manager 3 years before he started the hospital. I'd worked in the stock exchange as a student on internship. And up till today, Metropolitan always has interns who are here, between 10 and 20, mainly graduates, because my internship was very instrumental in starting Metropolitan. It's because it's during that internship that I met the investor, and that investor appointed me to look after his money, which I did. So when he needed someone to underwrite our share issue, he was prepared to do so. He died some years back. His name was Ankram Evans. Without his money, we wouldn't have been here because the same 90s, Kenyans had very little disposable income. So we are asking investors to put in 10,000 as a minimum to buy 500 shares. The maximum was, well, there was no maximum. We managed to raise 20 million. We borrowed 10 from the firm, a bank which is no longer there called Daima Bank. And so here we are.
I think that's a very interesting journey. So talks of you being a healthcare professional, but you're talking about the stock exchange. You're talking of going back to study management. But I think that's something that technical people like yourself, even right now, probably haven't taken advantage of those kind of skills. What is the gap still that you see? Because you are no longer just looking at Metropolitan, you look at even at the healthcare space. What is the space that is still available for raising money using the kind of tools that you did those many years back?
The first, the environment has improved quite a bit. Banks are now willing to lend to private healthcare. We have accepted that it should be possible to have private for-profit hospitals or healthcare facilities where we've shifted from ownership to value, which is what we should be looking at, the value proposition. What does it cost to get a particular service provided, a cesarean section, a neurosurgical operation? The focus should be on what does it cost and is the quality acceptable? The ownership of the facility should be secondary. So we have accepted that as a country. We now have more and more private for-profit providers. And that is important because that is a sector or the subsector which can grow. Because if you are faith-based and or a charity and you're trying to raise money, it means you're looking for donations. And donations can only go so far. If you're government, government has to also wait for taxes. It is limited to the tax revenue, and our tax revenue compared to 50 million people, there isn't too much per person, per capita. So the private for-profit is the subsector which is likely to grow much faster because it can attract capital globally. So we have private equity money. Wasn't available then, it's available now. At that time, foreigners were funding healthcare through the Ministry of Health. Now they are willing to invest in private facilities directly. So that's an avenue that is available. Then we have a stock exchange. It is now more open to startups. At the time you are trying to speak to the Capital Markets Authority, you had to have been profitable for 5 years for you to get a listing on a stock exchange. Now they have an Ibuka program, which Metropolitan actually is the mother company is a member of. And that Ibuka program allows companies that are startups to access money through the stock exchange. So to me, it's much easier now to get funding, whether it is from people who are buying shares in a company or banks that are providing lending or a mix of both.
Beyond the banks, because yes, things have changed in the last 20 years, a great deal. The private equity and even the stock exchange.
Yes,
we've seen quite some investments coming in, but maybe the part where I haven't really seen, maybe you are much more aware about this, is in utilizing the stock exchange.
True.
In the healthcare space largely.
You are very right. There is no single listed healthcare company on the stock exchange. And there could be a number of reasons for it. One is that if you are a private for-profit entity, every so often, private for-profit healthcare facilities take a beating that they are profiting from people's illness. And that's why it is very, very important that we focus on value. because the ownership of the healthcare infrastructure, you have faith-based, you have government, you have charities like Gertrude's, for example.
Yes.
At the end of the day, the user of the service, whether it's a company that is buying healthcare or an individual or even the government, the concern should be, given the right quality, how much is it costing to get the service provided? And the minute we move there for education and healthcare, then we'll get a lot more value even from the tax money, because we'll be paying not for inputs but for outputs. You've done a service, you get a payment, as opposed to where we give money in the hope that services will be provided. And so that is one reason that you are not sure how the market will take you. The second is that generally we don't have very many listed companies. I think there are about 70 of them. So we have to sell the stock exchange a lot more as an avenue for raising money. The third is the scrutiny, you know, and the governance. You have to have an independent chairman. There are a number of requirements that if you want to run a business as a private family-owned enterprise, the stock exchange is not a good place to be, because a lot of things, there's a lot more transparency. But conversely, it comes with better chances of continuity across generations. Because some of those listed companies have been there 70 years, 60 years. We haven't seen many companies that are listed collapse relative to the unlisted ones.
Now, we are at this facility. Maybe you can just give us in some brief what you really offer here. What kind of services and what you really kind of think in your kind of space, what separates out Metropolitan Hospital in the space where we are?
Well, there are several ways in which hospitals are classified. We have our healthcare facilities from level 1, which is community, to level 6, which is a teaching and referral hospital. Metropolitan is a level 5 hospital. The only thing is we are yet to do is the teaching. And the teaching, we are talking about teaching doctors. Otherwise, we train healthcare assistants. Everything else a level 5 hospital can do, we are able to do. And a level 5 hospital will be a multi-speciality hospital, meaning you can offer services across a number of specializations. And what we do here, I can talk about key areas of where we really want to focus. When we are upgrading the hospital, we were very keen to stop the traffic to India, because we think we should not be exporting dollars and our people who need healthcare to India for 2 reasons. A, we need to keep the money here for several reasons. 1, we need to keep the money here. 2 is that when our own people provide the service, they get experience. And therefore we'll have many more healthcare professionals in country who can offer care. The other reason, which COVID showed everybody across the world, and we've been talking about for a long time, but it was not as clear, is healthcare by necessity has to be local. Because when you have a heart attack, it's difficult to fly somebody out of country. You have to be able to get care where you are. You know, including local in the communities, not just local in country. So we wanted to make sure that we are growing our professionals so that they stay in country, because healthcare workers are global workers. Our nurses are going abroad to work. So we wanted to be part of the Kenyans, to be counted among those who are making sure that our healthcare professionals stay in country. The other reason is that there are doctors we've grown with over those 26 years who have become highly specialized, and we wanted to give them a place to practice. So among the areas we are in that there are not too many hospitals that are in is spine surgery. We are able to do spine surgery here, you know, both open and non-invasive. We are in neurosurgery. We have newborn intensive care. There are not too many neonatal intensive care units in the country. Then we are very, very strong in orthopedics. We have a very, very strong orthopedic team that, with specialists in ankle joints, specialists in knees, specialists in shoulders. So we are able to do joint replacements, and we are able to do it at prices that compare very, very favorably with the prices in leading parastatals like Kanyenje and Moi Teaching and Referral, and the new one, the KU one,
Yes.
and faith-based hospitals such as Kijabe, which offer very good service at comparatively good cost. So we try and benchmark ourselves to be closer to those hospitals in our pricing than in other private hospitals. Yes.
But then now, if you look back, because starting off a team of doctors, at what point did you really think? I think this is now beginning to gel. We've made some inroads. We've come out of the big challenges. Now things are beginning to work for us.
The first thing is that patients accepted us. So from year one, we saw a difference in the numbers of patients coming here. Throughout those 26 years, we've seen growth year on year. So the first is that the community around us accepted us. We did face a challenge because our logo those days seemed to be a snake, and people had trouble with the snake emblem.
Yes.
Because that's the time that devil worship was a big story in the country, and anything people didn't understand had something to do with devil worship. The second is that so having been accepted by patients, the next challenge was that our bottom line was not getting better. We were losing money each year for like 4 years. Okay, so the number of people coming is increasing, the revenue we are billing is increasing, but the bottom line is that we are digging a hole. And so we realized that, and that's partly why I went back to school, 2 problems. One, I knew medicine, not management. And secondly, operational controls were a challenge. So we made a decision very early on to computerize the hospital. We started in 1994, and we began the journey to digitization in 1999. We even tried to develop our own software then, but we didn't succeed. So we went into what we call a phase of consolidation for about 4 years, and turned things around so that we stopped hemorrhaging money. Because once you start losing money, it's like losing blood. You're on your way to death. But the real breakthrough came after the 2002 elections. The cost of money went down, the dollar stabilized, the economy was more liberalized, so you could import things we needed. So from 2002, we've achieved a lot more growth. Come 2017, we got in private equity money. 2016, going 2017, and that is when we are able now to upgrade the equipment and the infrastructure, because we couldn't have done that with the savings that we are making, or the surpluses that we are making. So 3 phases: 1999, 2002, 2017. Yes.
Now, you've talked a bit about going digital, trying to manage your systems. But let's talk broadly around technology.
Yes.
How has Metropolitan over the years adopted technology a bit more deeper to kind of even separate yourselves out and to survive as you? Maybe just a bit more explanation.
First, we have a very firm belief that we won't achieve UHC as a country. And now I'm talking as a chairman of KHF. With papers, with manual things. It is not going to be possible, right? Because if you look at the challenge of just managing claims, every Kenyan will make approximately 4 visits to a healthcare facility. If we are 50 million of us, those are 200 million claims each year. If those claims need people to go through, first to compile the paperwork, then to go through the paperwork, then to pay, you can already see that we need a very large army of people just to do that paperwork. And we see that as a big barrier to UHC. So we believe and have been working to ensure that the entire sector is digitally integrated, not just a hospital and an insurance company and an employer, but the entire value chain is integrated, because we are a very labor-intensive industry, especially at the provider end. You need very many people to look after the patients, because it's hard to digitize nursing.
Oh, yeah.
Secondly, we, from an operational point of view, organizations are not just Metropolitan, simply have to, many companies, if you look at very significant companies today, the largest companies in this country today, they are basically technology with a brand
Around it.
with a shuka wrapped around with a brand name, but inside is technology. Whether you are talking telecommunication or banking or finance, technology, remove the technology and the organization can't operate anymore or can't become any larger. So we are a very digital organization, and we keep looking at opportunities to eliminate paperwork. And we are very, very keen on integrations. We are the first hospital to integrate. Each month we are supposed to submit returns to the Ministry of Health. And we persuaded the Ministry of Health, and to their credit, they accepted, because they too have been digitizing. We are not the ones who told them to digitize, but we persuaded them that if we move away from writing 17 different records every month to submit to the ministry and submit the data electronically, they will save time, we'll save time, and the records will be more timely and more accurate. So we are the first in country, and we want to be a center of excellence, where others can come and learn. Because we believe that as a hospital, as an individuals, we have benefited from the knowledge of others. So we also should be able to share. Doctors swear an oath to share knowledge with each other. As a hospital, we exercise that by sharing knowledge with other healthcare providers. We use teleradiology and have been doing that for more than 10 years. So our X-ray reporting is not done here. We take the images, they are streamed, they are reported, the reports come back, and we are done. We are among the first hospitals to have a QR code for verifying our PCR tests, so that people are not issuing fake reports with Metropolitan on their logo. So essentially, whether it's COVID care or theater bookings or X-ray or imaging, we've been looking, every time we look at something, we ask ourselves a question: what is the opportunity for digitization so as to drive quality and productivity? And we are also the first hospital to introduce a doctor's portal. The doctors who practice here now can apply to be allowed to practice here digitally, get digital approval, do their billings digitally, prescribe digitally, get their account statements digitally, get their money digitally, the works. For the past 5 years, this is year 7, we have not owned a checkbook, because we eliminated all cash payments 7 years back. So we either pay you via your bank or pay you through M-Pesa, and it is integrated with our system. We don't pay on the M-Pesa platform. We pay using our platform, and we're integrated with Safaricom, so that the accounting controls are maintained from our own infrastructure. So whatever it is, whether it's HR or nursing, or clinical care, we are constantly looking at the opportunity to automate, to digitize, as a way of improving patient experience, and care.
Maybe for you also as a hospital, what has changed? What have you invested in? What have you looked at differently out of this pandemic?
Like most people, our first response to COVID was to try and keep it at bay. So, we put tents, started screening anybody coming here. So that was the first response, what I call the pandemic of fear, And we were not sure what would happen, whether it would still be there by the time COVID was done. But we were fortunate that during that first episode, our chief nurse was one of the Kenyans who went to Sierra Leone during Ebola. So we were better equipped than most places in doing infection control because Ebola is a much more dangerous disease than COVID. So we negotiated that first pandemic of fear by talking to our staff, by getting them protective equipment. And so we managed through that first wave. The next one was the wave of care. The stage where now the government system got overwhelmed and private hospitals had to be care facilities, not just isolating and then calling the government to transfer patients to Bagathi and other places. The system got overwhelmed. And it's an example of how healthcare has been in our country, that no one player can afford to manage to cater for the care needs of our people. And globally, there was also a demonstration that no one country is wealthy enough, equipped enough to deal with its population if a significant number of people fall sick at the same time. You need not just the health sector, you need the whole country, citizens, the army, everyone to participate in the response. So we went through the first wave where the biggest challenge was to get personal protective equipment, and we made a decision that whatever it cost, we are going to make sure our staff had personal protective equipment. It was quite expensive. We survived that one. We got into the stage where we now had to give care. So we converted one of our floors into a fairly large isolation and treatment center with 43 beds. We installed a COVID ICU and HDU from zero start at the beginning. Like most private hospitals we didn't have that infrastructure. So we got a license to be an isolation and treatment center and treated people. And I'm very happy to say that we had very good outcomes. We became a trainer from my experience through tele-training or tele-education, learning from others, collaborating with the public hospitals, as far as the one in Kisumu, the Jaramogi Hospital in Kisumu, because this was a new disease, so there were no experts. So KU, KNH, we are constantly collaborating with the other faith-based and private hospitals to share experience and learn from each other. And then we came to the point where oxygen became the problem, and we installed a plant, which you may have seen right at the roof, to cater for our own needs and to offer surplus to others. So by the time COVID was, the Omicron came and it ceased to be as dangerous as it was, we had an oxygen plant. Our ICU and HDU were twice as large as they were in the beginning. We had digitized a lot more because contact was being limited. For example, medical claims used to be very paper-based. Insurance companies decided they don't want papers anymore, so we joined the digitization wave. And then the vaccine came, so it became a vaccination center. And we actually did vaccinate more people than some counties. By the time the vaccination campaign, now we are not campaigning as hard as we were with the vaccination. We had vaccinated more people than some individual counties for free. We did not charge anyone. And we then became a travel and testing center. So as it is now, we have a level 5 laboratory, a level class F laboratory. That's the highest level of a lab you can have in a clinical setting. We are a PCR testing center for travel. We still have an isolation and treatment center in case we have, God forbid, another wave. And we are much better equipped digitally to provide telemedic care through telemedicine, through phone, through all these applications that came that allow digital communication. Yes, so we are much more resilient organization. We did not, we negotiated that space well enough not to send any staff home. There were hospitals that were like many organizations that had to reduce their number of staff. So we managed to keep all our staff. And more importantly, we didn't lose any of our staff to COVID. Not many got sick. The ones who got sick, none needed admission. Only one needed admission and they recovered. So it is something that we are very grateful for, because not, most people suffered loss at family level, and many healthcare workers lost their lives. So we are very grateful about the fact that ours are all still with us.
Oh, yes.
Yes. And they are now all vaccinated. I think only one refused to be vaccinated. The rest we vaccinated fairly early as we are vaccinating the community.
Now, as you go towards the end,
yes.
I know those early days when you are this young man and their friends putting up Metropolitan.
Yes.
So you are really towards maybe a point where now you are looking at the future.
Yes.
So at the Metropolitan Hospital level,
yes.
I think the next 5 years, I think this race to 2030,
yes.
2030.
Yes.
What do you really want to have Metropolitan look like by 2030?
We are pursuing, our original vision was to be in every provincial town in the days of the provinces.
Yes.
The young generation doesn't quite know we had things called provinces. They now know counties, but we had provinces. So our intention was to be in every provincial center. That vision got derailed by the cost of money and the capacity to expand. So we have been pursuing what we call a hub and spoke model. So this is the hub. We are equipping it before we venture out. So in the next 5 years, we want to be in more than one location, mainly through partnerships, because we have distilled management to a level where we believe we can go and now team up with other hospitals as investors to help them raise the quality of care that they provide by providing them with digital platforms, protocols, quality standards, the works. So we want to be a multi-speciality hospital with a hub and several spokes in key places. And we are looking at partners to do that with, because we have the expertise in terms of human capacity. We don't have the money, so we need a money partner to walk that journey with. Yes.
What about, are there maybe some specialties, some areas you probably are looking at going forward that you probably don't have at this time?
We are very, very keen on not so much new specialties, but improving care for those with long-term illness. Because too often you find somebody who was diagnosed with hypertension, they got lost to follow-up, and then they come to hospital with a stroke. They were diagnosed with diabetes, and they come to a hospital with kidney failure. So we are very, very keen on perfecting long-term care for certain conditions, beginning with hypertension and diabetes, because they tend to complicate into many more things. Because we believe with our digital capabilities, we can track care right from digital monitoring tools at home to ICU, if anybody needs ICU. So our focus is on NCDs, non-communicable diseases, because we believe that we can improve care, and that these people who have these long-term diseases can be kept healthy and productive in the community, as opposed to spending money in a hospital. So although we are a hospital, we are aiming to become a community healthcare provider.
Yes.
By giving care right at home, mainly driven by digital tools. You know? In another year, we'll give patients a portal, you know, where you record your vitals, or it's connected to a watch like this, which is a wearable devices, so that right from here we can keep track of what is happening and advise the patient at what point they need to come back to the hospital, offer teleconsultation so that people don't have to travel. So we want to really be in that space. So even as we develop physical infrastructure, just like what is happening to banking and finance, we want the patient to be their own doctor. We want to enable patients to take care of themselves, or their caregivers to take care of them right at home by providing technological support.
Now, at the personal level, you know, maybe at 26 years, there's still a lot to do, and we are glad you are wearing many hats. But here, what do you do these days? Because we are out here, and I know doctors are taking care of patients up there. And what kind of things do you want to do personally as you go forward?
The first one is mentorship, because for our country to, my personal view, Metropolitan is a means to an end. It was never an end in itself. We were to raise the quality of care in two ways. One, by providing the care ourselves, but more importantly, by influencing, you know, the quality of care provided throughout the country. Because the founders were cognizant of the fact that not all Kenyans would fit in Metropolitan. And even our own relatives go to other facilities. My mom is based in Murang'a. You know, if she is seriously sick, she will not get here. She needs care closer to home. So although we are private, we are very keen on what happens to public healthcare, because it is the first foundation to care in Kenya. Whether it's improvement in financing or improvement in care itself, we have to make it more accessible.